Please let's kindly mute our mic. Please mute your mic. If it's on, kindly mute it.
Auntie Nata. Onta chugwa jonalo. Eji.
Sure.
Okay, so our speaker for tonight is Dr. Andrew. Good evening, everyone. I don't know if you can hear me. Please confirm. I spoke earlier, but I don't know if someone
Yes, we can hear you.
Okay, all right. So
You can hear you.
okay, thank you so much. All right, Dr. Andrew, please, are you ready? Hello, sir, are you ready? If you can hear me.
Yes, I can hear you, Victoria.
Okay, sir.
Yeah.
All right, sir, you can start. It will be beautiful. We start on time, so we'll be able to finish on time.
Okay then. Thank you. Well, thank you for the opportunity to share knowledge with you guys again tonight. I appreciate it. Now, the topic for tonight is obtaining informed consent for rehabilitation. Obtaining informed consent for rehabilitation is one of the mandates of World Health Organization, a prerequisite for us to integrate rehabilitation into universal health coverage. So it's not a choice. It's something that should be okay. Okay. So, like I said, obtaining informed consent is one of the mandates of things that should be done towards implementation of integration of rehabilitation inside universal health coverage. So it's something that we all must learn, irrespective of our profession. Everyone involved in rehabilitation inside universal health coverage, either at the tertiary level or primary health care level or community practice, must learn informed consent. So it's a mandate. Now there is an MLTB runs workshop for the past 2 years on obtaining informed consent. So basically what we are doing within the LCL is just to give a bridge version of the topic for us to have a broad idea, and hopefully when the workshop comes up in one of the MRTB workshops, I will advise everyone to still take it In the last workshop for this particular topic, it was facilitated between between I and a lawyer. So, and the whole of the presentation takes over 5 hours. So, what we are having tonight is just an abridged version. Thank you. So, basically, this is the overall content, and I'll try to quickly move to it. So, the background is, what do we need to take informed consent? Legal and ethical implications of written and verbal informed consent. Approaches to determine a person's decision-making capacity, including policies and practices governing how, when, and from whom informed consent is obtained and documented, including when a person does not have decision-making capacity. Interviewing for consent, I have removed it when processes, risk, benefits, and potential outcomes to people and their families with various levels of health literacy. Also, I have dropped it so that we don't go too far. So these are the key documents for this presentation, which is one, International Conference for Harmonization of Good Clinical Practice, EU Directive on Good Clinical Practice, World Health Organization Handbook for Good Clinical Research Practice, and Department of Health Reference Guide to Consent for Examination and Treatment, Health Professions Council, UK, Standards of Conduct, Performance and Ethics, and CSP Consent and Physiotherapy Practice. But we must know, despite using international guide, that we must comply with international ethical standards and best practice. We must also take into consideration our socio-cultural perspectives. This is quite important factor for consideration when we seek consent. We must also understand that, unlike most countries, Nigerian population often pay out of pocket to receive services for rehabilitation. Even though we have the national health insurance, and many states also have health insurance, the reality is that the number of periods allocated for rehabilitation is not adequate. So Nigerians still pay heavily out of pocket. So we cannot apply international standards in a linear way to our system. So whenever we are taking consent, we must build in a lot of factors and look at our situation. But irrespective of our situation, it does not exclude us from taking consent or absolve us of blame if there are malfeasance and we did not take consent. I hope I'm clear. So, what's the background? The reality is that disabling conditions, which often those of us as professionals in rehab, they are life-enduring conditions. What do we mean by life-enduring conditions? They are conditions that cannot be treated with a medication. They are conditions, even though the problem is stagnant as in the effect has happened, but it keeps changing. In some instances, some condition changes for the better, while some can even change for the worst. When it comes to children, it affects the trajectory of their development in a negative way often, such that they are never ever able to catch up with their peers. So that is what is meant by life-enduring conditions. It stays with the person for the rest of their lives. So disability, all these conditions that we call disability conditions could present as poor adaptive functioning and mobility problem. But it's not always functioning and mobility problem that create disability. There can also be expression of behaviors, mental and cognitive functions without necessary mobility problem. So often we might look at what we're saying here is that it's not every time that disability have to be described in terms of contractures, deformities, paralysis, not being able to move or not being able to balance. Mental cognitive behavioral disorders are also disabling conditions. So not being able to adapt to situations, conform with peers for a child is also a disability. So we must disabuse our mind that disability is only expressed in terms of mobility problem. So disabling condition also could come from effects of multiple domain impairments. For instance, a patient with Parkinson's disease, diagnosed with Parkinson's disease, can also have associated problem of visual impairment, might have a comorbidity of cardiac problem, maybe is hypertensive, is diabetic. Yeah, Parkinson might be the reason why the patient is referred, but the patient has had cardiac problem for years. You also have diabetic problem. So what we are saying here, when we talk about disabling conditions, they are life enduring. Parkinson is a problem on its own, right? But now this patient have got cardiac problem. This patient is also diabetic. So it's probably visiting and under different medications or several medications. Particularly in childhood long-term conditions, the initial pathology problems often in children remain, but with increasing age, needs change, and other comorbidity usually emerges. What that simply meant is that a child that was diagnosed with cerebral palsy, for instance, at the age of 9 months, whatever we assess, we are assessing as at 9 months. In the next 1 year, this child is now 1 year, 9 months. If the child has not attained what he should do at 9 months, is also have not been able to attain what he should do at 1 year, 9 months, when compared with his peers or her peers. And often, same way, they have multiple comorbidity changes. So as they get older, the initial problem is cerebral palsy, but their needs change. And it continues to change. A child at 1 year, 9 months is not the same child at 3 years. This same child that grew to be 3 years, and we are still managing the child at 10 years, it's not the same child we started managing at 3 years, because their needs changes, their demands changes. Also, as they get older, if it's a female child, maybe by the age of 13, 14, these guys start menstruating, body changes takes place. All these changes does not affect the cerebral palsy that the child has initially. They are still there, but the child is still growing, so there are changes that keeps occurring on the child, and this means their movement, adaptation, their balance, their ability to cope with the environment, with their peers. It gets more and more challenging as the year goes by. So what that means basically is that these multiple comorbidities affect development, physical emotional, psychological well-being of children and their families for the rest of their lives. So why do we need to take consent as rehab professionals? There are several challenges in health system and the health administration before 1930s. This is the cause for legislations and regulations that are gross abuse of authorities, gross abuse of privileges by those who are in charge of delivering services. The situation got worse post-World War II, when prisoners of war were being used for research, were being injected with lethal poison, with syphilis to see what will happen. Some, their brain was opened, things planted just to see what will happen. So post-World War II, the abuse of research and non-taking consent becomes a serious problem all over Europe and America. And there was an urgent cause for reforms in research and health governance. This research and laws and ethics is still ongoing till date. So it's an evolving process. So obtaining consent in the management of clients and research of all health conditions became mandatory and regarded as good practice. So it is not an option for us to say whether I take consent or I do not take consent. Like I said, it is a mandatory training for everyone working in rehabilitation in universal health coverage. Everybody must do it. So, what is good practice? Good practice is about the way we carry out our duties and responsibilities to others. Good practice is to develop frameworks of practice guidelines and clinical governance rules described as clinical pathways. Every clinical pathway must also have its governance structure. Its pathways are guiding standards of steps to follow towards provision of service, maintain equity and quality. While governance set out principles, standards, and mechanisms to deliver organizations' goals. One of the things that clinical pathways and governance should provide inside rehabilitation is that we must have peer coordinators and how they should operate. We must have peer support groups. And we must have a process where our choice of intervention and costs is justified. Then, every aspect of rehabilitation, we must have autonomy and accountability to take consent, but be accountable for it. All these we will try to clear where will be the challenges, because everyone is going to wonder, okay, what is the role of a care coordinator, for instance, inside rehabilitation? I will say it briefly, like a care coordinator is an assigned rehab professional who understands the condition, the debates around the conditions, and the multiple challenges many patients do have, and know what services and the best services that this patient should explore towards good recovery. This care coordinator is there to support this individual with challenges to be able to navigate all services and get the best of service. Abroad, many institutions have care coordinators. In some places, some patients were assigned immediately a patient is registered to an hospital. They are assigned to a care coordinator. Care supports. This is where patients complained will be listened to. What is their need? What is their priorities? Care supports will give them. It's possible that sometimes a patient needs does not match what the provider is providing. Care support will call the attention of the experts that this patient's needs is not being met and advise on what the patient wanted and how they can meet it. As part of, for us as professionals, we must, inside rehabilitation, justify our choice of intervention and be able to deliver it safely, also be able to justify the cost of that intervention. Then autonomy comes in and accountability. So who takes informed consent? We will try to answer the economic accountability because this is where clash can come. For instance, the example I gave earlier, when, let me say, a cerebral palsy child, from the day the child was born, the CP is seeing the medical doctor, pediatric neurologist, is also probably seeing a pediatric cardiopulmonary. Now he has to see pediatric physiotherapist. This same child requires the service of P&O. This same child need the service of special language therapist. In all these, we have mentioned about 6 professionals that is going to attend to one child. So who takes consent? Then how do we justify accountability? Because when you take consent, it means the life and death of this patient, I am responsible. If this patient did not get better, it's my duty, it's my responsibility. Give me query, challenge me, because I took the consent. So this brings us to legal and ethical implications of written and verbal informed consent. Like I said, a lawyer took this aspect the last time, and his lecture is a 2-hour lecture. Sometimes we don't know what law says until we run foul of law. Many of us don't know Nigerian law penalize medical professionals severely on the issues of consent taking. But, however, we are not conscious of it so much because in our environment, most of our clients don't take us to court. In fact, we are next to God. Doctor said, this is the instruction of the doctor. Some therapists will even give the patient their own instruction, not what the patient wanted. So they laud their personal opinion on patient. All these are illegal. But we don't know there are laws that punishes such activities. So if you happen to come across an enlightened patient and you do some of the things we do, it might end up in a serious legal problem. However, we must be conscious that the law is there, even though patients are not using it against us. But remember, the day you are going to find a patient that will take it up, one cannot claim ignorance. So guidance for obtaining informed consent. Over the next few slides, we will present some of the complexities and issues surrounding the process of obtaining informed consent. Try to use this section to establish what you already know about gaining informed consent, either for research, practicing your field. Also, use all the following slides to identify where you need to enhance your knowledge. So any further evaluation you can do on it, research you do on this topic will enhance you professionally. The final outcome for us is to be able to navigate around gaining informed consent to protect ourselves from malfeasance and ethical and legal challenges. Guidance to obtain consent. Rehabilitation is a client-centered practice based on consent. This is an agreement to respect their preference and values. So obtaining informed consent is good practice for working with vulnerable persons. You need to hear them out. It is part of framework for attending to everyone with dignity. Consent enables us to overcome dignity challenges. Guidance to obtain consent. When seeking consent for rehabilitation, be specific about what you want to do in treatment. Don't give a vague description or your role in the patient's management. At that particular point, what are you going to do? And if you need to pay, and what others will do. If the patient is solely in your care, then consent has to be taken. If it's not solely, then you will need to prioritize. Who is the major provider? Who are the support providers? This might raise more questions than answers given, but we should, as professionals, be able to navigate them. So we need to establish the relevance of therapy for clients, prove the efficacy of therapy, justify its cost. In rehabilitation, treatment ideas should incorporate expected activities that carry over into clients' daily routine. And we should consider specific preparation for specific function. What is consent? Consent is voluntary permission or authorization by a patient for a specific procedure to be carried out on his or her body. It's a voluntary permission or authorization given by the patient, not given by you. Be informed consent or informed consent. It can be written or verbal consent. The consent can be valid or invalid. What is informed consent? Informed consent is legal condition whereby a person can be said to have given consent based upon a full appreciation and understanding of the facts and implications of any actions, which the individual being in possession of all of his faculties. That is, the patient is conscious, not mentally retarded or mentally ill, not influenced by, nor is judgment impaired, either by intoxication, by drugs, by sleepiness. This is the only way verbal consent or informed consent is given. That is, the patient is briefed. The patient has to be briefed on what the whole procedure is all about. And while the patient is being briefed, it should be noted that this patient is well aware of everything that was being explained. Uninformed consent is exactly the opposite. It's based on assumption, which 90% of us do in the clinic. What do I mean by that? When a patient comes to a teaching hospital, to a general hospital, to physiotherapy department, or to P&O department, or to the speech and language therapist department, what do? We simply assume, because the patient is in our department, he has given us authority to do anything we want, to use our body. But that is not supported by law. That's not supported by law. That because it's present in our department, give us authority to touch him without asking for his permission to be treated. But we must also understand this patient have the right to decline treatment. So this is where we should caution ourselves. So if a patient comes to the department and decides to decline treatment, in the same way, we have no right to say this patient must take our treatment because he has a right to DAMA. He has a right to refuse treatment. He has a right to go home and refuse treatment. So if he has a right to decline, then to accept to be treated, which is giving us informed consent to be treated. So informed consent is a process by which the subject voluntarily confirms his or her willingness to participate in a particular trial or intervention after being informed of all aspects of the trial or intervention that are relevant to the subject decision to participate. This is, again, when we are either using the patient for a research or we are using the subject for research. Let's get it clear again. That a patient comes to our department does not necessarily mean he's going to be enrolled inside the research without him or her consenting for it. Consent to be treated in the clinic is different from consent to participate in the research, even if he has given consent to be treated. It doesn't mean he has consented to being used for research purpose. There are two things entirely. So be aware, Nigerian law does not allow us to just switch or use anything on a patient like that, even though, like I said, most of our clients don't take us to court. And we pray we should not be taken to court until, but let's be mindful. We shouldn't run foul of the law because, like people, lawyers will say, there is no ignorance in law. So informed consent means to open lines of communication, either written or verbal. Informed consent means leaflets or conditions, pictures of services or facility in our department. We can have leaflets in our department that describe what type of service we provide. Informed means information is available that is appropriate and adequate to every patient that comes to our department. Informed consent means the disorder, the disease that the patient is suffering from is thoroughly explained and the patient is aware of the pros and cons and benefit of therapy. Informed means we tell the patient the natural cause of the condition and possible complications and the consequences of non-treatment. We don't compel patients to undergo treatment, but we can tell them what can happen or what might happen if they refuse treatment. Still, it's not our role to compel them that they must receive treatment. We must also tell the patient comparative and alternative treatment options available, the potential risks and benefits of treatment options, the services available in your facility, the duration and approximate cost of treatment, expected outcome, support and follow-up that is required. Informed also means we allow the patient to report on dissatisfaction, and they should know when they come to the therapy department, they know whom to complain to. In fact, it is recommended that every department should have a drop box of complaint box where authorities, let me say the Servicom, can come to any department and open the drop box. In this way, patients actually can drop information inside the drop box, complaining about services, complaint about an individual, complain about a malfeasance without being victimized, which can be dropped anonymously. This also allows the patient to report on abuse and whom to contact. The patient undergoing rehabilitation under this process have a right to change or cancel appointment. The advent of electronic data collection have changed the way we give and use consent. These days, we have messaging apps, telephoning, we have online forms, now we have electronic medical records. Each one of them, what is important is that what we must be up to date in the records we keep, and we must understand every one of it have legal implications. As professionals, we are in charge of our thoughts, words, and actions, and we take responsibility for our actions and inactions. We must understand that the advent of communication have made it legal that when you send a text message to someone or to a client, even if there is maltreatment based on that information, it is legal tender. A recorded voice message is a legal tender. Online forms often cannot be edited. Once you have insert an information, is a legal tender. Again, our electronic medical records that we use now in many hospitals is a legal tender, because once you insert information there, even if you delete it from your own end, your CMD will still have it in his own end. The records will have it in their own end. So don't document what you did not do inside EMI. Document what you see, how you see it, when you started, and when the patient gave consent, let it be recorded. Because all information under EMI is also a legal tender in court. So what's the difference between verbal and written consent? Again, we all know what is verbal, what is written. It's an oral acceptance that's communicated to the patient. It is language dependent, hence cognition is required. Verbal consent is an implied consent. Because why is it implied? If it's not recorded, the patient can deny that, no, I didn't give you permission to do that. I didn't give you permission to touch me there. I didn't give you permission to do that. Because it's an implied consent. There's no record of it. Patient can change. These are our views. Yeah, it does not require signing. But where disagreement happens, one's judgment may be questioned. Is your word against the person? Is your word against the person? And if somebody wants to frame you, is a big problem. Written consent is best, is required literacy, however, could be reviewed, deliberated before agreeing, captured in designated form, signed by both parties, and copies kept. So what is the ethical and legal implications of written and verbal informed consent? Ethically, patients should be given opportunity to ask questions and clarify doubts. Patients have a right to choose. Compelling a patient to take a particular treatment, even though there are alternatives, is an abuse of ethical process. Patients have right to information of the services and what other alternative he or she might be able to explore. Patients have a right to discontinue treatment and discharge against medical advice. The legal is that act of coercion, untruthfulness, claiming what an intervention will not do or will not achieve is regarded as abuse of privilege or intimidation. So when you are coercing a patient to receive a particular treatment, you are showing fear and all that. Legally, it falls under intimidation of the patient. And it's also covered under abuse of your privilege as professional. Legally also, handling and moving without consent is regarded as battery or invasion of privacy. What do they mean by that? That a patient, just like I said earlier, a patient comes to our department because he was referred for osteoarthritis. And we simply assume, because it's in the department, we don't need to take his or her permission before we start managing our knee or our hip and all that, or his knee or his hip is wrong. Touching a patient without taking a consent from the patient, explaining what you want to do, how you are going to hold them, where you are going to touch them, under law is regarded as battery. Under law, despite the fact that this patient is in your department, is invasion of privacy if he did not give you consent to be touching his or her body. It's an invasion of privacy. Rules of dignity in care and dignity in action applies in these cases. So what's the difference between giving consent for research and consent for rehabilitation? As therapists, all of us, we know we take consent for research. But many of us don't know we need to take consent for rehabilitation for that patient. So we only take consent if we want to use the patient for research or we are recruiting client for research. But both requires. Now, what's the difference between taking consent for research? Research has a duration period, so the consent is one off. While you are recruiting, patient gives consent. In research, not every patient requires to give consent to participate in that research. The researcher exclude or include based on factors. So it cannot demand a patient who does not conform with the research goals and parameters because there is always an inclusion and exclusion criteria. Often research can be an audit process or service intervention. Service process evaluation or intervention evaluation. In rehabilitation, all factors are inclusive. There's no exclusion. What does that mean? I'll come back to the man we gave an example who has Parkinson's disease and who also who had cardiac problem. He has had a cardiac problem. It's actually a life case. He has had the heart issue before he suffers Parkinson and is also diabetic. Now, this same man had knee, knee replacement. In rehabilitation, you don't exclude a patient based on one factor in his or her body to qualify for rehabilitation. Whatever the problem of the client, everything is taken into consideration. Remember, in research, we have exclusion and inclusion. In treatment, we don't have inclusion-exclusion criteria. We must manage the patient, including all the factors. This is where consent is key. Because based on multiple factors this particular client has, the client can claim at any time that he is not improving. It's always easy to get an improvement in your research work because you have excluded so many things. In the clinic, the patient can deny that he has ever, that he might even say that what he came with, he has gotten worse since he started therapy. And it's possible because he has multiple comorbidities that can change for the better or for the worse. But taking consent means you have adequately elaborate all pros and cons, and the patient have agreed. So in rehabilitation, consent is dynamic because intervention can change. You may start treating a stroke patient in a particular way just for you to realize that you have to change the management because the blood pressure is persistently high. Or was referred for stroke. While you are managing the patient, you realize that this particular patient has other problems that you did not properly evaluate. That might trigger you to change the whole plan of management. In research, you don't change plan of management. You don't review your plan of management. You set out your goal. I'm going to do this within the next 6 weeks. And that's what you do. But in the clinic, patient can go for the good or for the bad. So you need to continue to evaluate yourself. You need to continue to change your handling regarding the case. Sometimes in the clinic, we have a bad case. Suddenly, within about 2 therapy sessions, you see a gross improvement that requires adequate changes to enhance the results. This is the reality of life, not the reality of research. This is the reality of life, of clinical practice that we are all engaged in, where there are need for substantial changes. Even if you are taking consent, review the patient and inform the patient of new development that you see, then reaffirm the consent. Don't say because he gave consent initially, now you are seeing that you didn't know that this patient had a renal problem. Now the patient today that I didn't know has renal problem until she complained about something and I was demanding of her to go for further check. Then she now told me that she was admitted for renal problem 3 months ago. But I've been seeing her since last year. There was no time she ever told me she has been taking medication for renal issues. But her telling me today that she has been managing renal issue, now let me understand why we have not had substantial improvement. Because it's a factor that I did not build into his plan of, a plan of management. She didn't tell me. Even though I've reviewed her several times, she didn't tell me that she's got renal issues at the background. That's why we need to be careful. We really need to be careful. What is similarities between consent for research and consent for rehabilitation? They are both cone. One is an inverted cone, while the other one is the upright cone. Generally, we need to look at the background, the context, specific literature in the area as regards the evidence-based, the research, the treatment aim. Intention to treat is mandatory for children. Always remember that. Why is it an inverted cone? For research, we take a whole process and we are looking at coming up with a specific answer. For the treatment, we take a whole problem where we are looking for a specific identity for progress. Comparison of hierarchy of consent for medical and consent for mental and cognitive research. Again, this is another regulation on its own. The parameters for taking consent for research, we all know that. But when we are taking consent for mental capacity, in which you are looking, you have to justify that the patient understand what you are saying. Remember, one of the characteristics of informed consent is that these patients have cognition, understand situations, understand all the explanations, the pros and cons of each or a problem. This is mandatory. However, when it comes to mental capacity, you might need to do extra. Yes, take consent directly from the patient wherever possible, but you must be able to assess the mental capacity because this case is a mental case. Again, we are guided that when you are doing research on mental capacity, trial entry after consultation with a relative or a friend is better. Don't just enroll a mental disorder case into your research. They must first do trial entry. You know, despite all your assessment, you must do trial entry. Trial entry after consultation with an independent person nominated by the researcher. That is, you as a researcher investigating mental problem, get an independent person to also interview the patient before you take the consent. You don't need to do this in regular research, but in mental case, you need to validate yourself. Trial entry after consultation with a registered medical practitioner who is not involved in the research is important. Trial entry after a procedure agreed by the Research Ethics Committee. So what are the policies? I'll try and rush through now. What are the policies, the practices governing how and when and from whom informed consent is obtained and documented, including when a person does not have decision-making capacity? These are just guides. These are just guides that we use. So when consent needs to be obtained, the Department of Health, this is a replica of what WHO said, and internationally, the EU standard said, people who can give consent, qualifying relatives, We must also identify whom among us can obtain consent. That is in the hierarchy of the professions, or how many professionals are involved in the case. Who among us, when we have about 5 professionals treating a particular case, who among us should take consent? When is consent required, we must identify that and what information should be provided. One of the criteria also we must look at is consent voluntary, or do we coerce the patient, or is it freely given? Remember, consent can only be valid if it's freely given. Any consent that was taken based on coercion, intimidation, is not valid. Does it matter how patient give consent? Yes. The refusal of treatment, children, case, non-competent adults, and offenses and penalties. Those are the parameters, but we are not going into the details. I mean, some of the references indicate that, so you can read more of how to evaluate all those parameters, right? So, who give consent for adult? Every adult and adolescent is assumed to be competent, except proven incompetent. As long as you are of age, except you are proven incompetent, but it needs to be given voluntarily, no coercion. Appropriately informed, the patient must also be seen to have capacity to agree or disagree. Participation does not influence treatment or care. That is, whether the patient decline or accept, it does not and must not be held liable for declining treatment, or declining to participate, or declining to give consent at any time. So don't use it against them. But if you feel unsafe about that, because a patient whom you want to take consent and declines to give you consent, you also need to get a witness. You say, this patient declined to give consent, and yes, still wants to be treated. Let it be transcribed. The same patient, if he's there to give problem, who gives consent for children below 18 years old? When it comes to children, giving consent, each case is considered on an individual basis. Each case is considered on an individual basis. A child is not eligible. Only parents and guardian is eligible to give consent. In children's case, age and maturity is also play a lot of rules in consent. So, like we said, generally parents and guardians should give consent for children. But when age and maturity comes in some instances, children are allowed to give consent for themselves. That's why it is case by case. The age of the child matters, and also the maturity of the child matters to give consent, and it's acceptable internationally. In this case, Gillick principle or Gillick competence comes into play. So what is Gillick principle? Gillick principle says that we grow chronologically and we grow mentally, emotionally. Let me repeat that again to my friends. Gillick principle is talking about that we grow chronologically by our age, the date of birth, and all that. We also grow mentally, emotionally, psychologically. Now, we are expected to grow physically, chronologically, grow mentally, grow emotionally. However, sometimes we have people who grow physically, who did not grow emotionally. So you can have a woman of 50 years old who is totally immature. And I know people like that. I know people like that. I know people that, even though you will see her as adults, often I ask myself, why should a woman like this get married? Because there's everything about her is totally immature. And she's the kind of person who sees fault in every other person except herself. There's fault in every person. Anything that happens, she will blame it on anybody, but except herself. Never ever look at herself. She's totally immature. So, but that by the side, I just give you a typical example. So, somebody can be, Gillick is saying somebody can be 40 years old, but mentally, emotionally, this person is still 10 years old. Yet you can have someone at the age of 14 who is very matured, very balanced emotionally. What is this telling us? It's not everybody we see as elderly. They are elderly chronologically. They are not elderly in terms of maturity. And I'm sure many of us will have seen people like that you will wonder their age, and you start asking yourself, why is this person behaving this way? The only reason why you are going to give them respect is for their age, but they are not matured. Their behaviors, their manners of reason, their manner of attending to issues does not reflect their age. That's what Gillick is saying. So it's possible that you have a patient that is 18 years old. If you assess and mentally, emotionally, this person is still at 7 years old, he has no capacity to give consent. He has no capacity to give consent. However, a 14-year-old whom you interviewed knows what he is doing, knows what he wants, knows exactly and can understand, can actually stand for himself and give consent of what I like, what I don't like. That's what Gillick principle is talking about. On the lighter mood, I study people a lot, maybe because I work with children, and Gillick principles applies a lot. When you work for a long time with children, you understand the sense in Gillick principles. However, I do deal with even adults. So sometimes, no matter what some people say, I will not respond. Not because not because I just want to ignore them, but they are simply not making sense. And I can see that talking and having discussion with this person, I'm going to be stressing myself because he's not going to get it. And maybe some of us also have witnessed such situations in which you want to have a mature discussion with someone, and every time you started a discussion or to open the topic, it probably will change the topic into something else, or it's even saying something entirely different that you are going to get yourself stressed out because it's just not processing anything. When I see such people like that, I always know them. This is Gillick man, right? So let's quickly move on. So despite using Gillick principle, consult the family. Let the family also contribute. If the child chooses not to consent, the parent can give consent, provided it is in the best interest of the child. If separated consent, that is, if partners are separated, consent is accepted from the parent who has authority to consent to treatment. They have to decide who has that authority. Is it the father or the mother? let them pick somebody who has that authority. Participation in research should never affect treatment of care. Mental and cognitive impaired children, parents or guardians have the capacity to consent for treatment on their behalf. However, the main treatment provider or specialist is under dual obligation to the child and to the parent. You need to carry the child along and also carry the parent along. Because if you cannot get the cooperation of a child during rehabilitation, you are also going to have problems. So what about taking consent from somebody who is incapacitated? This comes under the, again, Mental Capacity Act covers vulnerabilities. So you need to protect the vulnerability of the person. There may be cases where individuals are temporarily incapacitated, such as after a road traffic accident. Then somebody needs to stand up for them. There is also advanced decision consent. It's not common in our side here, but it's very common in Europe and America, where someone gives consent of what should be done when he becomes incapacitated. He already wrote it down. Some say, okay, once I get to this level, remove this part of my body, remove that part of his body or her body, do this, do that, and all that. So he has given consent advance. A lot of Europeans does that. It doesn't have to be that when they have problem before they give consent. Some will do it voluntarily. Go to hospital, put it inside their record. If this happens, once I get to this stage and any of this happens, I give consent that this is what I wanted. Who can give consent in a disease case prior to death if the diseased person have given consent of what should be done to him or her, it should be honored. But we should need to consider family sensitivity. The family may object, even though individual consent has been obtained prior to death. You might need to invite the hospital attorney into this because you, as a person, you know when this patient gave consent of whatever he or she wanted, right? Even though this patient is no longer there, but if the family object to whatever the consent the patient gives, let a lawyer attest to it. Because within the family, there can be quarrels later. Using a nominated representative to confirm the individual wishes may also be useful. So who can give consent? The principal provider, delegated person. Note, despite delegation to principal provider, the person should also take responsibility. Consent form. The detailed process, time, explanations, and witnesses should be inside the consent form. Documentation is also important, and consent form should be attached to our documentation. Take consent that is transcribed, validated, print out, and signed. Before using a consent provided, despite written consent, despite having a written consent, it is good in some instances to consider chaperoning. Even if the patient gave you consent, take chaperoning in some instances. Consent is valid only when freely given, provided the patient understands the nature and consequences of what is proposed. It has duration of validity. If no problem is detected, you should retake the consent. So rehabilitation is complex. There are key points the principal provider requesting for consent must know. Rehabilitation service that has principal specialty provider is under a non-specialist jurisdiction to take consent. I hope that is clear. Rehabilitation services that has principal or specialty provider is not under non-specialist jurisdiction to take consent. Taking consent is dependent on the competency and proficiency to manage the particular condition, knowledge of the condition and proficiency and skill to treat the condition, understanding the debate surrounding the interventions, both advantages and disadvantages, ability to justify choice of intervention and no psychological mechanisms at play. Other issues we might consider when we are determining who to take consent or who should take consent: drug and medications related induced effects. How do you measure the outcome? Who will you tell the outcome? Would they come to any harm? Would the provider come to any harm as well? Courts highlight 4 components of rehabilitation. It has to be client perspective. There has to also be mutual participation with healthcare professionals in decision making. Every rehabilitation plan must set outcomes that are meaningful to the patient. Is on what patients consider most important to them, not what you as a provider considered important. Emotional support, coordination of care across multiple service sectors, and continuity of therapy. When we need to document properly what we have done, how we did it. So it's always important in rehabilitation to use the IC, and in many cases in children, we can use the ICF combined with GMFCS. We can also use descriptive writing if we know how to do that. Write abilities and inabilities. Also assess rehabilitation domains. It is important when taking consent to identify a main problem of the patient, because the patient will come with multiple comorbidities. Main problem relates to finding key issues and the baseline factors. Write out your functioning findings and provide possible explanation for them and relate them to a baseline factor. Provide at least 2 reasons to justify your choice of intervention. Develop treatment ideas you should address or related to key issues. So what are baseline factors? A baseline factor is one thing that could be changed that will impact positively on the overall treatment outcome. Is one thing that could be changed that will impact positively on the overall outcome. This should form the intervention priority. What is the key issue? Is something that might impact upon your assessment and treatment. Something that might impact positively or negatively upon your effectiveness. A key issue addresses the fact that no matter how competent professional you are, there are some problems that will impact your effectiveness that is not under your control and is a key issue. Family problem is one. Religious beliefs is another. Late diagnosis, late referral is another. Or even non-compliance with medication is a key issue that will impact your intervention. Where one is going to find a lot of challenge is at assessment for emotional functions when taking consent, sensory and sensation, mental and emotional cognitive disorders. All these can impact consent taking, assessment of vulnerabilities, evaluation of how much they understand of their main problem that are playing in their life and condition is one way. When you are dealing with emotional problem in a client, look for how to synthesize the baseline and the key issues and discuss these with the patient. Bring together the baseline factor and all the key issues which form main problem of the patient and see how much of their baseline problem and key issues they understand and how they think it impacts them. That will give you an idea whether this patient is vulnerable or not. So with the assessment for vulnerability, let's just define it. A vulnerable person is maybe in need of hospital and community care services by reason of physical or mental disability or that disability related to age or illness. We can say a person is vulnerable by reason of they being unable to take care of themselves or unable to express themselves or unable to protect themselves against significant harm or exploitation. There's so many conditions that exposes individuals' vulnerabilities. These include most conditions with information processing difficulties, the disconnection between the sensory, perceptual, and cognitive issues at play, which play a major role in mental and emotional disorders. The SPC, that is the sensory, perceptual, and cognitive disorders, play a major role. Other conditions that are very vulnerable in rehabilitation have dementia, schizophrenia, most learning disabilities, autism, Down syndrome, some genetic unexplained conditions, many cerebral palsy patients, patients undergoing bouts of depression, anxiety, can be very vulnerable. As professionals, we need to overcome dignity in challenges. That is dignity in our care and dignity in our actions. One of the measures of a civilized society is how well it cares for its most sick and vulnerable members. We need to learn to attend to everyone with dignity, including ourselves. So what is dignity? It's a term which is used in two major ways. Dignity is the quality of the way we treat others as humans. Dignity is how they perceive themselves. That's personal dignity. Dignity is about self-esteem, our self-respect, which is our self-image. We should do all that we can to help each other maintain our self-esteem, not to bring each other down in our self-esteem. We don't talk down on each other. So what are the challenges we face generally when upholding dignity? I know a lot of people talk about human rights and all that, but nobody talk about the fact that you can only respect human rights when you learn to treat yourself and others with dignity. fight less about human rights. When you understand that what I want, also others want, when you learn to treat yourself with dignity, then you will understand what it means not to abuse others. Because often those who are abusers, bullies, basically, they lack self-dignity. They are not dignity conscious. That's why they bully, that's why they abuse, because they themselves, they have very low self-esteem. So they try to compensate with intimidation of others. These are severe dignity challenges. So what must be overcome? Respect. Support people with same respect you will want for yourself or a member of your family. Have a zero tolerance of all forms of abuse. Privacy. Respect people's right to privacy, autonomy. Maintain the maximum possible level of independence, choice, and control. Person-centered care. Treat each person as an individual by offering a personalized service. Self-esteem. Assist people to maintain confidence and a positive self-esteem. Loneliness and isolation. Must always, as professional, act to alleviate people's loneliness and isolation. Communication. We should listen and support people to express their needs and wants. Complaint. We must ensure people feel able to complain without fear of retribution. Engaging care partners. Engage with carers as care partners. Disclosure of information. We don't share people's information under any circumstance without taking their permission to do so, or using their information either in written, video, or audio in whatever manner should be with the consent of the client. Thank you, everyone. I stop here. Thank you.
All right. Thank you so much, Dr. Andrew. Thanks so much for your time. And I believe we all learned something from today's class. So if you have any question or you are confused about a particular slide, this is the time to ask question. So if you have any question, can you signify by raising up your hand so you can ask your question before we call it a night? Anyone with a question? If there's no question, that means we all.
There are questions. Vicky, there are questions. Suleiman Aminu, please go ahead.
Okay, sir. Okay, Mr. Suleiman, you can ask your question. You've been
Good evening, sir. Good evening, moderator. Thank you very much. Hello, sir. Am I audible?
Yes, sir. We can hear you. Go ahead.
Sorry, please. I don't know if I missed it.
Yes, sir. We can hear you.
Based on the definition given by you gave in the slides concerning consent, how can I consent? Sorry, how can I get consent from an unconscious patient? Thank you, sir. Please, is my question clear?
Yes, sir. Your question was clear.
Okay, thank you,
I
ma'am.
don't know if Dr. Andrew, sir, did you hear his question? I don't know if he's still in the call.
Okay. Sorry, I was muted earlier. I was muted earlier. That was what happens. So, like I said, there were instances where that somebody have to stand in an unconscious case or in an emergency case. Somebody have to stand in, and that is accepted. That is accepted. But once the patient comes around, then responsibilities needs to be handed over either to the relation and all that. So they validate that consent. But no patient in an emergency situation should be declined consent. Now, if the patient is in ICU or let me say ICU, right, and you are treating the patient, the consent that's already taken by the doctor or the nurse to bring the patient into ICU for care should stand for you because you are a visiting professional. You are not permanently inside the theater. I hope that makes sense. You know, inside the ICU, a nurse is providing service, medical doctors are providing. So there are many other people who are providing services. It might not even be just one consultant, but one of the consultants have taken consent for that particular patient. Consent means I'm responsible for the life and death of this patient. I'm responsible and I'm answerable for anything that happens to this particular patient, right? So if you as a therapist want to take consent for an unconscious patient that you only come to administer and you go, you are not the one permanently there. I mean, you shouldn't put yourself as the main provider when there are others who are there 24 hours of the day, right? So you might not have problem with taking consent in that instance, right? However, if this patient leaves ICU and started coming to the Department of Physiotherapy, for instance, and you are now doing cardiopulmonary rehabilitation, then you need to take consent for that because the doctor that took consent in ICU cannot say if the patient collapsed and died in your hand, in your department, is going to be answerable for that if it becomes a legal case. You need to wash his hand. The same way, you should wash your hand clean in his own jurisdiction area. I hope I'm clear. Hello? Hello? Is my answer clear?
Okay, so I don't think you can actually answer now. But please, sir, can you actually respond through the chat if your question has been answered? Thank you. So please, Mr. Sunny, can we have your question, please? All right, thank you. So I say that this question has been answered.
Can you hear me? Am I audible?
Okay.
Yes, we can hear you, Mr. Suleiman. Can go ahead, sir.
Thank you, sir, for the enlightenment and there is this. I saw a video of a man and a lady and a young man, and there was this issue of consent in the third world. It's something else. So this lady was about to be hit by a car, and the man quickly grabbed her away from the car, and she was saved. At the end of the day, she sued the man for not taking her consent to be saved.
Hmm.
In fact, I just wonder in our health system, somebody coming into emergency, maybe they sleep on the road and they sleep, and at the end of the day, the person came back alive and said the swing whatsoever thing that is, taken care of, that saved his or her life. What can we do about that? Then when it comes to what's it called now? Okay, now we talk about a patient in the ICU, so it means that as a therapist, we don't need to still seek any consent for the patient in the ICU while managing the patient. All right, my question now, my third question is, which body in Nigeria are really involved when it comes to issue of consent? In some of our institutions, maybe health and other institutions. Thank you, sir.
Okay. Let me first let me start from the bottom. Your first question, I didn't get it clearly because it was breaking. Now, as regards ICU, remember one of the things we said here is that when a case is under a major specialist and that specialist have co-contributors, that specialist automatically take that responsibility because we are working in a team. For instance, let me make it, if you are managing a stroke patient and this stroke patient develops tightness of the wrists or wrist drop, or contractures of the wrist, let me put it like that, and you now request for P&O to make a cock-up splint for this patient. The P&O takes measurement, send the patient back while they are preparing for the cock-up splint. After the cock-up splint, they administer the cock-up splint, the patient continues with therapy. You now tell the P&O to take consent for improvement of that stroke patient. If the P&O take the consent, he's simply saying that well, if the patient did not improve, he's responsible. But the only thing he has provided is a cock-up splint. He's not the one doing daily treatment. So if you are treating the patient and you are not doing the right thing, and the P&O is signing that, it's hold me responsible. Maybe that's what we don't understand. Like I said, patients don't take us to court in Nigeria. All these things we are saying, in a place like UK and other, nobody wants to sign. I could remember there are many times I will avoid signing or taking consent and signing, even in the clinic while working in the UK. I wouldn't want to sign. It's not every time I want to sign because I understand the implication, right? One of the things that bothers us most is documentation. The period we spend the documentation because we know whatever you put down will be held against you. So I wouldn't want to take a consent in a situation where I know I'm not a major provider. So I wouldn't be so if the P&O say, oh, I'm also a P&O and I'm also involved in the management, let me take the consent. He's simply saying this patient that have stroke is undergoing physiotherapy and probably will be under physiotherapy maybe for the next 6 months. But right now, he's on admission, he has stroke, he has wrist drop. To prevent wrist tightness and all that, you request for cock-up splint to maintain the fingers, to maintain the wrist, but he's not taking consent for the outcome of the stroke when the only thing he did in this situation is just to provide cock-up splint. So if this patient decide to go to court and they bring out the consent, they go and call the P&O, you will say, no, I'm the one who managed. So if the patient did not improve, you should hold me liable. That is what consent is all about, that you are responsible. It's like you signing a reference letter for someone that if this person commit crime, come and arrest him. So it's not about pride or anything. It's about being accountable. So if this patient is in ICU, there is a surgeon, maybe this patient had cardiac surgery and has tracheostomy and all that. So you come, you do your own breathing exercises and all that, right? But you decide to take consent while There are so many other things that this patient have done. Maybe he has done surgery, is on tracheostomy and all that. The surgeon, before they operate and all that, they have taken the consent, but I want to take consent again for that. There's no need for that at that particular point, but they have taken consent. They have taken that consent. And your role, do your whole part and leave the rest for the surgeon. However, once the patient comes around, he's not coming to the physiotherapy department. Even the surgeon will expect you to be accountable because he has done his own. Once the patient leaves the theater, the surgeon in charge of the theater does not want to be involved in any outcome of that. Even if they did laminectomy, let's come home properly. For the surgeon, once the patient is stable, he has come out of from anesthesia, is okay. They have been able to certify now he has come around. The surgeon has washed out his hand in that case. If the patient did not improve, no surgeon who did laminectomy will take responsibility that it's the surgery that failed. That's why the patient did not improve. They will call the therapist. There's no surgeon that will take responsibility after the patient has moved out of his theater, gone out of ICU, is now undergoing therapy. If there's any problem and the patient and there is a case, they will call the therapist. The surgeon will say, I did my own work perfectly. Okay. However, you, the therapist, now that you take over, you should assess the patient. You should take consent for what you want to do. It also saves you because if this operation has not been successful, you are the one who is going to carry the responsibility because the surgeon will say, as long as, for a surgeon, as long as the patient did not die in the theater or ICU in his hand, operation is successful. But it would not, no surgeon will take responsibility for rehabilitation recovery. You have to treat that. So let's be clear in this circumstance. Now, for someone, I didn't get the first question. What I assume is that somebody said he's the main care provider or he's the main carer and he's the one who is going to sign for this particular patient. Well, one have to look at the age of that person and do your proper assessment. If this patient can sign for himself or herself, he should be able to do that. However, if somebody now insists that he's the one who is going to sign, maybe he is the one who is paying the finance. Who is financing whatever the patient is, the costs of whatever the patient wants to do. That's why he's claiming that he wants to be the one to sign. So you have to look at the circumstance of why he wants to sign on behalf of this patient. However, you as a professional, that's where you are going to play an intermediary role. Why do you want to sign for her when she can sign for herself? Okay, I'm the one paying. You know he's doing it because of payment. He wants to show that he is the one who is in charge. Then I will also listen to that lady, right? Because she owns her body. And no one should own somebody else's body. I cannot be running my idea on somebody else's body. It's not my body. I need to value her. I need to appreciate her. What she wants with her body is what she wants with her body, and we must give her dignity. That's why, again, dignity challenges comes in. Irrespective of whoever is paying, always remember, you as a professional, respect the individual's dignity. He or she should be treated with dignity. You should protect their self-esteem. Being in hospital environment lowers patients' self-esteem naturally because they are not in their terrain. But it's not. Dealing with people with dignity does not even have to be in an hospital. When you know your self-worth, right, you treat yourself with dignity, you will definitely know how to treat others with dignity. When I see somebody or people who does not treat others with dignity, it only tells me who they are. It doesn't mean that person don't have dignity. I hope you get me clear. The person who is treating somebody in an undignified way is only telling me who he is. It doesn't mean the person whom they are treating without dignity does not deserve dignity. They are the one who have problem. They are only showing themselves. It's because they themselves lack self-esteem, lack self-respect, lack dignity. So they will treat others in an undignified way. There's no way you will respect yourself, you have value for yourself, you have self-esteem, and you will now lower other people's self-esteem. That is not right. You don't shame people. What do you want to gain? Lowering other people's self-esteem for you to feel good. Doesn't seem right. Not like it's not even right that you need to lower somebody's self-esteem so that you can feel good about yourself. It's a serious problem. But don't take consent when you know you are not primarily responsible. If I know this patient only requires something out of me, it's not a consistent thing, then I shouldn't struggle to take consent. It means I'm saying I'm responsible if you don't improve. That's what consent means. In a place where people insurance is paying, in a place like UK and other, everybody avoid even signing consent. Even when consent is signed in an emergency, in a place like UK, the doctor will ask you, everybody working as a team, medical doctors in the UK will force you to sign the consent because he wants everybody's hand inside it. So that if I'm going down, all of us must go down together. It's not there in Nigeria that we think, medical doctors believe I own the patient or the patient is consultant patient. That mentality is affecting us. But it is because people don't go to court. I have seen situations where doctors run into problems and they are looking for a way to dump the patient. And they come to me to bail them out because we don't want this patient to go to court. That's when the reality comes in, that you don't own a patient, right? Thank you. Dr. Ayuku Emery. Dr. Ngozi, please go ahead.
Okay.
Dr. Ngozi.
Okay, sir. Good evening. Thank you so much, sir, for this great lecture, as usual. Your lectures are always very, very interesting and educative. Now, this particular topic, it's just like an eye opener. I'm more concerned about this issue of good practice. Where we talk about which eventually you, according to the lecture you gave us, you said good practice is to develop framework of practice, guideline, clinical governance, rules described as clinical pathways. Then there are a lot of demarcations, like we have the care coordinator, the care supports, and we should justify and all that. So coming down to our own terrain here, that we are still struggling with a lot of things, I'm just wondering, a lot of us down here, we play multiple roles. So there's no demarcation per se. We just do things, we just assume the way we do our thing here, like the care coordinator. One person can be both the care coordinator, also do the care support, also justify choice of intervention and all that and all that. So I'm just wondering, um, how do we educate the patient? Because a lot of them they don't know about these things. And that is why they are not taking us to court. Only
Yeah.
very few of them that are informed or maybe enlightened that have traveled. I've never really heard. I've not seen, maybe there have been cases, you know. So I'm just wondering how we have to, is it in our place to educate the patient to know about who is supposed to, when things go wrong? Okay, this is the person. Because what I see mostly, aside research, people just say, okay, their research is on its own. It's not the same type of informed consent you use for research, you use for treatment. There are differences, So how do we now let the patients be aware of these things? Because even we as the professionals, the demarcation, can you just talk about it? Because I became really interested in that area of good practice. Thank you, sir.
Yeah, you are welcome, my sister. Now, good practice framework, when I've already incorporated all of us, irrespective of our profession, the steps to follow to provide equity in service. Now, let me give brachial plexus injury. Brachial plexus injury are clinical practice guideline for it. And when we develop CPG for brachial plexus injury, because we actually have one for Nigeria, we agree that a child who had brachial plexus injury should be referred to therapy within 7 days. Before we select 7 days, we have looked at many countries all over the world. And we are being realistic that will Nigerian doctors, will they refer in 7 days? For instance, in Kuwait, a child who had brachial plexus injury, therapy should start within 3 hours. In Canada, within 7 hours. In Saudi Arabia, within 7 hours, including even cerebral palsy. What are we saying here? Clinical practice pathways or guidelines give us a frame where all of us can work consistently across board. Here in Nigeria, because we don't have any standard, any particular doctor does whatever he or she wanted. Even inside the same hospital, it's not constant. You can find a medical doctor who will refer cerebral palsy within 2 days, within 1 week, if he can see that, okay, this child suffers bad asphyxia. But another one is not going to refer in the next 6 or 7 months because there is no standard guidelines. In other countries, these guidelines, once it is agreed on consensus, becomes a law to be implemented. But we don't have. Every management has its own guidelines. And this guideline, medical doctors, nurses, everybody complies with it. So you know when this should start, when you should refer, when you should do A, B, C, D, when therapy should come in, when the nurse comes in, everybody have agreed on that. This creates consistency. In Nigeria, we don't have any of that. Now, what is the role of care coordinator? You, as a person, can be employed as a care coordinator in UK. You can coordinate. So it does not have to be that, okay, I'm a physiotherapist, I can be care coordinator. Being a physiotherapist, for example, you know the problem. What we are doing under care coordination basically is that now a stroke patient comes into the hospital. This patient requires about 8 services. Sometimes in our clinic, the day the patient have to come to your clinic for physiotherapy, this patient also have another clinic to attend. This patient also have another clinic to attend. And there is a conflict. So some patient will be pleading, I have to see so clinic on Thursday. I have this clinic. on Tuesday, I have this clinic on Friday. Please, can you let me come? Can you give me an appointment on so days? Then the therapist might say, no, we run only this kind of clinic only on Tuesdays. We cannot give you Wednesday. We cannot give you Thursday. Right? A care coordinator listens to this patient, knows that this patient access multiple services. The role of care coordinator now is to make sure this patient is able to access all these services at a less burden on the patient. The care coordinator helps this patient to negotiate ways to make it easy for them. We have not imbibed the character yet. That does not mean we should not teach ourselves the character of care coordinator, because if, which many hospitals are already doing, I know BUK now have a rehabilitation center. Bauchi too is building a rehabilitation center. So all these hospitals that run rehabilitation center must have a care coordinator, because in a rehab center, all the professions must be available. An appointment must be structured in such a way this patient can access all those services at one go rather than on different days. So who is going to plan synchronization of all these services to make it easy for the patient? The care coordinator comes in. It's a role on its own. It doesn't take away your profession. If you are appointed to be the care coordinator, it doesn't take away your profession. Right? Yes, it might mean you do more of care coordination than actually rendering physiotherapy service. If you decide to take it and you have a huge volume of patients that you are doing care coordination, that's service you are providing at this period. It doesn't take away your role that, yes, you are still a physiotherapist, or you are a P&O, or you are a speech and language therapist. Your goal is to make sure this patient access all services in a synchronized way with less burden. Yesterday, I was talking to one of my junior colleagues, in the clinic, and I said, listen, when I had a patient and I have to stay in the hospital for 3 days, that's when I knew that patients are suffering in our hospitals. I have to go to one end to pay, collect receipt, go to another end, drop the receipt, then take sample to one place. I was going back and forth, back and forth, back and forth. After 3 days, I tell myself, if this patient is discharged, I myself, I should take myself for admission. And I wonder, some patients do this every day in the clinic. Our hospitals are not designed the way it is right now for care coordination, but every rehabilitation center must have a care coordinator to make it easier. Maybe by the time we start implementing the right things inside those rehab centers, some teaching hospitals might actually imbibe the principle of employing care coordinators. Finally, let me say this. I know a physiotherapist who work as disability assessor in Scotland, and that is his role. So patients come to their center to assess their level of impairment and all that, and recommend what kind of aids and tools and devices they should give. Taking up these roles also creates employment. Though in our training, we have been trained to assume all our knowledge is just about pull the hand and pull the leg. That is the reason we also take up so many other work, and we don't even see that all our colleagues that are gaining jobs in America, in Canada, in UK, not all of them are working the way we are working. Some of the roles that we take as an added work is actually a duty for somebody. It's actually a duty for somebody. But I believe that things will get better as we go on. I mean, if you have your own rehabilitation center, Dr. Ngozi, get a care coordinator that will help you book all your patients in such a way that they come at the right time where they will see all consultants they will need to see. Not that they will come on Tuesday to see the neurologist. They will come on Thursday to see the ophthalmologist. Then they will come again on Friday to see the orthopedic surgeon. If the appointment is on Tuesday, they will come. You know they are going to see the orthopedic. They will see the ophthalmologist. They will access all their services within the center before they leave to ease their body. That's the role and duties of care coordinators. I hope I'm clear. Dr. Ngozi has gone.
Okay. Okay, sir. Thank you so much. I think that's all for the questions. And here, if you can look at the chat box, we have a link also. That's the link to the quiz we have for the topic that was treated tonight. So please do well to copy the link, yeah, and then answer the questions. It will be sent to the group, WhatsApp group or YouTube. So this is the only place you can see or get the link. So please do well to answer the questions, and that will be all for tonight. So thanks so much, everyone. Dr. Sorry, PT Dara, do we have any other announcements for the house? If there's no announcement, then we'll call it a night. Okay. All right. Okay. All right. Okay. Just a minute. You're
Yeah.
unmuted.
Thank you so much. All right. It will be dropped on YouTube. So I don't know people live streaming on YouTube.
No, we don't
No,
have we don't have
we don't
anyone
have
on
anyone
YouTube
on
right now
YouTube right
because
now
I
because
can't
I
see an
can't see an
100.
Okay, okay, okay. That's fine. There is nothing else to be said.
Okay.
Everything. Oh, yeah. Thank you, ma. Thank you so
Welcome.
much, Dr. Andrew, for tonight.
All right.
All
Thank
right.
you so much.
So,
Good night, everyone. Have a wonderful night's rest.